So for today, we are going to start off with an introduction, which we have. We're going to talk about what are eating disorders, provide some definitions, as well as what is harm reduction. So we're going to define what it is, its rationale, as well as some practices. We're then going to talk about harm reduction in the context of eating disorders and really consolidate everything. Finally, we are going to kind of go over what kind of resources we have available for you, as well as offer the Q&A. Just a reminder to keep yourself on mute as we are recording at the moment. And if you have any kind of comments, feel free to use the chat. Our objectives are to understand the connection and justification for harm reduction within the context of eating disorders. And we're going to learn harm reduction strategies that can be used this holiday season and beyond. A little bit about NEDIC. We are a nonprofit charity founded in 1985 based out of the University Health Network in Toronto. We run a national English-speaking toll-free helpline and a live chat service where we provide information, resources, referrals, and in-the-moment support. Our helpline is anonymous and confidential, and importantly, you do not need a diagnosis in order to access our services. We do also have a searchable online directory of over 700 treatment and support providers across Canada. And we do prevention-based work through education, like resource development and training opportunities like this, and kind of help with promotion campaigns. So I'll pass it back over to Caitlin.
So very briefly, a little bit about Sheena's Place. We are a community mental health charity that supports people affected by eating disorders and disordered eating. And we do this by offering group-based support. So no individual treatment or therapy, but we do offer many different types of groups. So support, skill building, body image, expressive arts, and nutrition groups, all facilitated by mental health clinicians and educators. We offer about 30 weekly groups, most of which do take place online. We do have a couple of in-person options for folks in Toronto, and all of our groups are free of charge and based on self-referral. So no eating disorder diagnosis is required. And anyone age 17 and older in Ontario is welcome to register for groups. I'll share a couple of links in the chat later on today with some more information about our programs. All right, but for now, let's talk about eating disorders. So what are eating disorders? First of all, we'll be using the terms eating disorders and disordered eating today for consistency, but we do acknowledge that these terms might not resonate with everyone, and that is totally okay and does not take away from the validity of anyone's experience. So broadly speaking, an eating disorder is a collection of thoughts and behaviors related to eating and exercise that's harmful to physical and mental health. And like all mental health challenges, eating disorders occur on a spectrum. So we all fall somewhere on this spectrum, and that can change over time. And so if we look on the left-hand side, we will see someone who might have a more positive or neutral relationship with food and with their body. So this person might experience higher levels of body acceptance. They might engage in more flexible, balanced, and intuitive eating and movement. And self-esteem and self-worth would not be solely defined by the body. As we move towards the middle, you'll see what we've called symptoms of disordered eating. Many of these behaviors are actually quite normalized in our society, even celebrated in many cases. And despite having this label of disordered, many of these behaviors, I would argue, are quite normal responses to abnormal or disordered or traumatic situations. On the right-hand side, you'll see a list of eating disorder diagnoses based on the DSM, or the Diagnostic and Statistical Manual. With the exception of orthorexia at the bottom, you'll see an asterisk there. This is not technically a diagnosis in the DSM yet, but we anticipate that it might be added in the next edition or in a future edition. So for the purpose of this presentation, we are not going to go into detail about what these terms mean. We will direct you to NEDIC's website, which is linked on the bottom of the slide, if you would like to learn more about some of these behaviors or diagnoses or what they mean. A quick note that I will share, though, about diagnoses in general before moving on, is that, like with many different types of challenges, receiving a diagnosis can be empowering for some people. It can validate their experience. It can allow them to gain access to treatment or to support. However, we know that diagnoses can also be unhelpful or even harmful. We know that the DSM is based on a Western medical model and is scaled to white norms in many ways. And so much of the research that informs these diagnostic categories we see here, and in the way in which mental illness is conceptualized in general, tends to exclude people of color and folks who experience other forms of marginalization. When it comes to eating disorders specifically, diagnoses can be especially problematic because they act as gatekeepers in many cases to publicly funded treatment and support. Due to stigma and stereotypes about who is impacted by eating disorders, doctors and other health professionals often overlook many people needing support. All right, so moving along to some risk factors. So why would a person develop an eating disorder? How would this happen? Well, eating disorders occur as a result of diverse biological, psychological, and social and environmental factors. The development, the type, and the duration of an eating disorder is influenced through a unique combination of these factors, which can also be categorized in the following ways. So we can look at predisposing factors. So these are things that would make someone from the get-go more likely to develop an eating disorder. So things like childhood experiences of adversity and trauma, experiencing discrimination and oppression, as well as a family history of an eating disorder and genetic factors as well. Precipitating or triggering factors, these are things that might happen in a person's life that, when combined with the predisposing factors, would increase the likelihood that someone develops an eating disorder. So these could be things like separations and losses, disruptions in interpersonal relationships in other ways, new environmental demands, decreased self-esteem, things like dieting as well, and many more. This category, I think, is especially relevant during this time of year. So during the holiday season, we might see things like seasonal depression or pressure to engage in New Year's resolutions as being precipitating factors in some cases. And then we have perpetuating factors. So these are things that maintain the eating disorder over time or that interfere with recovery. And so we'll see things like cognitive effects of starvation and illness, cultural approval of disordered eating behaviors, food insecurity, weight stigma, and much more. Again, this can be a big part of the holiday season. So social reinforcement at holiday gatherings, comments that family or friends make about bodies or about food choices. And again, pressure to engage in things like New Year's resolutions. So those things can kind of fall into both of those categories. Okay. So I'll pass it over to Emily to take us through the next part.
Thank you. So based on global prevalence data, it's estimated that 2.7 million people in Canada have a diagnosable eating disorder. What we also know is that the specific data is very lacking, and likely even more people are experiencing distressing symptoms. Eating disorders also have the second highest mortality rate of all mental illnesses, and it is second to the toxic drug crisis related to opioids. The leading causes of death include suicide and cardiovascular failure due to caloric restriction, use of diet pills and laxatives, and self-induced vomiting. We also know that rates and severity have increased during the COVID-19 pandemic, and this can be attributed to things like the behaviors helping to cope with emotions, maintaining a sense of control, as well as it being a consequence of food insecurity and a loss of support. Fundamentally, mortality and health consequences are not dependent on body weight, and early interventions can lead to greater chances of recovery. And contrary to the popular belief, eating disorders do not only impact young, thin, white, affluent girls and women. While there is a growing recognition that eating disorders do not discriminate based on a person's identity, it's important that we move beyond this narrative to really examine the unique factors that influence the development and maintenance of eating disorders in diverse populations. For example, experiencing racism and shadism increases a person's likelihood of developing an eating disorder and receiving support, as does experiencing fat phobia, ableism, transphobia, and more. And so on the next slide, we're just going to look at intersectionality and holidays. For the holidays, there is a kind of significance to religion in both its presence and absence. So, not celebrating Christmas, Hanukkah, or Kwanzaa can increase feelings of isolation. Since eating disorders are as diverse as the people they affect, we can see how the pressure to celebrate holidays and feel joyful in December can be really difficult for various people in diverse and intersecting ways. You'll see on this slide we have several examples. People who identify as 2S LGBTQI+ experience eating disorders at up to 5 times the rate of their cisgender heterosexual peers. As well, trans and non-binary folks are at a particularly heightened risk. During the holiday season, there's the possibility of increased isolation for them due to rejection from family, whether that's related to coming out or being unable to come out, and ultimately not really having a safe space or a supportive environment for them to be who they are. People who experience food insecurity are more likely to develop eating disorder symptoms than those who do not. It's really hard to have a relationship with food at all, let alone a positive one, when access is unstable. So during this time, there may be added pressures of buying gifts or spending money at events or for gatherings that can really exacerbate food insecurity. Indigenous folks are just as likely, if not more likely, to have eating disorders as white people. However, due to systemic inequality, they are less likely to access treatment and support. And so for this holiday season, it can be a time of healing and celebration for some Indigenous communities, perhaps those who engage in ceremonies for winter solstice, or those who have integrated Christianity into their kind of traditions and customs due to their upbringing and being separated from their roots. But for others, Christmas specifically could be a time of aggravation from societal structures of power, consumerism, capitalism, and colonialism. People of all shapes and sizes experience all types of eating disorders, and health consequences are not dependent on weight. And so during this time, we really see diet culture being rampant and prevalent, and this can really exacerbate fat phobia and weight stigma. All of these different intersections and identities can pose as some challenges that may exacerbate disordered eating. And so I'll pass it back to Caitlin.
Okay, so let's talk about harm reduction. Harm reduction is a term that is typically used in discussions about substance use. So that might be the context with which you are familiar with it. It's more broadly defined as a philosophy and an approach to policy, programs, and practices that aim to reduce the health, social, and economic harms associated with health-related behaviors in folks who are unwilling or unable to stop engaging in those behaviors. And so the purpose of a harm reduction approach is not to assume that extinguishing a behavior completely or permanently is feasible or wanted. Instead, harm reduction aims to reduce the negative consequences associated with certain behaviors while respecting a person's autonomy and self-determination. And so we could do a whole webinar or many webinars about the history of harm reduction. So this will not do it justice at all, but very briefly, harm reduction is rooted in several social movements throughout the 60s to the 80s, including the women's health and reproductive rights movement during second wave feminism in the 70s, as well as through grassroots and activist responses to the HIV/AIDS crisis and hepatitis C infections over the years. Harm reduction can also and has also been applied at many levels. So at micro levels, meaning interpersonal and individually, meso levels, so that would refer to communities and organizations, and also macro level interventions, so government, law, policy. So I'll use a substance use example to illustrate those different levels. Harm reduction practices for a person who uses substances at the individual level might be, let's say, using substances only when in a controlled environment or in the presence of trusted others. At an organizational level, this might look like a shelter that provides overdose prevention kits to their residents. And on a governmental level, a policy might come into place that decriminalizes the use of certain substances. So these are all different examples of harm reduction applied to substance use. Harm reduction also understands that a person exists within a broader environment and that interacting systems, including systems of oppression, influence a person's ability or willingness to engage or disengage with certain behaviors. So a little bit of interaction and reflection here. Harm reduction might not be a concept that everyone initially easily identifies with, but it's something that we all practice in different ways on a regular basis. So there are some examples up here in the slide, and I'm curious if anyone wants to share any more examples in the chat of how they practice harm reduction in their daily life. I see wearing a helmet when riding a bike. That's a great one. Yeah, using a life jacket if you're in a boat or near water. A seat belt, absolutely. Wearing sunscreen, yep. Sunglasses as well, someone's saying. Yes. The buddy system when traveling somewhere new, totally. Drinking at bars instead of alone. So being around other people in general when engaging in certain behaviors. On the note of drinking alcohol as well, like drinking a glass of water at some point during the course of drinking alcohol would count. Thanks, everyone. Hopefully this is making everyone think a little bit about the ways in which we, in many cases, automatically engage in harm reduction, right? Sometimes we don't even think about it, like putting on a seatbelt. That might be something that you just do when you get into a car and you don't even realize that you're doing it. Others might be more intentional, like putting on sunscreen, let's say. You're welcome if you think of more as we go through today to put those in the chat as well. All right, I will pass it back over to Emily.
So let's think about harm reduction in the context of eating disorders and why this approach is relevant. We know the exclusive goal of abstinence is often unrealistic and insensitive to individuals' life circumstances. However, the requirement that individuals become abstinent from engaging in symptoms is a very common yet high threshold condition for receiving eating disorder treatment in Ontario. Programs in other provinces often share similar criteria. This can make treatment very inaccessible and unsustainable because an individual may be unwilling or unable to refrain from symptoms if they haven't developed alternative coping strategies for managing difficult emotions or experiences of trauma. And this can really set people up for failure, which, as you can imagine, may only reinforce eating disorder behaviors. Harm reduction acknowledges that social inequalities affect both people's vulnerability to developing an eating disorder and their capacity for dealing with it. As mentioned, there are extremely limited services and supports for people experiencing eating disorders, and there are extensive waitlists for publicly funded treatment programs. Existing treatment and support options are not culturally relevant or appropriate for many people. And this might mean, not seeing diverse staff and providers. The food that is being offered may be very culturally limited, and the therapy modalities are also limited to whatever is considered evidence-based. As you'll recall, members of marginalized groups are also less likely to receive an eating disorder diagnosis, which significantly impacts their ability to access treatment in Canada. When one's support resources are so limited, the expectation of abstinence can be really unrealistic. How can we expect people to abstain from symptoms when there is a lack of accessible, culturally appropriate, gender affirming, and weight inclusive care? Furthermore, a harm reduction approach sees that penalizing or reprimanding people who engage in eating disorder behaviors does not lead to symptom alleviation in a meaningful or sustainable manner. Instead, it often leads to further health, social, and economic harms, both for the individual who engages in the behavior and for the communities and societies in which they live. Ultimately, reprimanding people for engaging in eating disorder behaviors just induce shame and stigma, and consequently amplify those experiences of marginalization. This may drive people to continue engaging in behaviors to cope. In this way, expecting abstinence can be completely counterproductive. What harm reduction practices can offer is accessibility and affordability, and it can serve as an entry point for one's recovery or seeking care. Harm reduction can also be integrated into professional treatment, and it can be done independently. So there's a bit more flexibility there. Let's move on to the next slide. A harm reduction approach sees that abstinence is one of the many useful goals an individual can set in their recovery to reduce harm. And so what this means is that harm reduction, recovery, and abstinence are not seen as mutually exclusive. For some people, asymptomatic recovery, so not having any symptoms at all, that is the goal. Others may have different definitions of recovery, and that can include the following: decreased frequency of eating disorder symptoms, reduction of disordered thinking patterns, increased ability to tolerate difficult emotions, some kind of resolution of body image or self-esteem challenges, developing and or maintaining a loving, meaningful relationship with others, reducing isolation, and perhaps an overall improvement in well-being and quality of life. So I'll pass it back over to Caitlin to talk about some of the principles.
Thank you. So we will spend the next little bit going through 5 different principles of harm reduction and speaking to specific connections to eating disorders with some specific examples that can apply to the upcoming holiday season. So the first principle is humanism. So this idea that people do things for a reason. So recognizing that eating disorder behaviors provide some benefit or many benefits to the individual is really important, right? People don't engage in eating disorder behaviors for no reason. It's not a choice. There are many reasons why those behaviors are happening. So we know that symptoms are often, essential coping strategies for dealing with difficult emotions, stressful life circumstances or events, and in dealing with trauma. We know as well that engaging in symptoms often provides a sense of control or relief or comfort or familiarity. And so if you are someone who is living with an eating disorder or disordered eating, it's a lot easier said than done, but doing your best to, trying your best not to judge or blame yourself for what's going on, and reminding yourself that eating disorders are not a choice and that your symptoms are, ultimately protecting you in the absence of other coping strategies or external supports. And so during a time of year that is particularly challenging for some people, so the upcoming December holidays, whatever we want to call it, it makes sense that a person might go to familiar or safe coping strategies like the eating disorder. And so educating yourself on certain health risks posed by various behaviors and deciding how you would like to address those could be a part of harm reduction. And we will provide some more specific examples of that as we move through today. If you are supporting someone with an eating disorder, reflecting on moral judgments that you might be making about their behavior and really doing your best to refrain from making those judgments is important. Educating yourself as well on the specific health risks posed by symptoms and considering how you might support someone in mitigating the harm caused by those behaviors. Again, we don't have enough time to discuss the specific health risks posed by various symptoms or behaviors, but we will share a slide at the end that highlights some key red flags when it comes to medical monitoring and some resources about accessing that as well. So moving on to the second principle, which is pragmatism. So this is the notion that perfection is impossible. We know that completely perfect health behaviors are impossible to achieve, regardless of the avenue of one's health or life that we're talking about. And complete abstinence from eating disorder behaviors might not be feasible due to a variety of factors, and Emily named many of those factors just now. So remembering that with harm reduction, abstinence from symptoms is not the prioritized or unassumed goal. If you're someone living with an eating disorder, considering what might be interfering with your ability to meet your own defined recovery goals would be important. So things like access to food, stigma, and I think it can be a delicate balance of acknowledging the barriers and then feeling almost helpless in terms of how to approach those, because most often systems are the problem in terms of accessing what we need for recovery. But within that, examining, are there things that are getting in my way for reaching my goals that I do have some sort of control or self-determination over? If you're someone supporting someone with an eating disorder, also considering what might be interfering with their recovery and remembering that these factors are often outside of individual control. So it's not just a matter of telling someone to change their behavior. Again, it's not a choice that these things are happening.
And so the next one is individualism. What this means is that every person presents with unique needs, strength, rapacity to harm, and therefore, requires an individualized approach to care. So it's important to remember that there's no one-size-fits-all approach to treatment or recovery. And while there may be research that supports certain modalities or practices, this doesn't mean that those things will work for every individual. And if they don't work for someone, it does not mean that there is something wrong with that person. It also means that every individual has the right to question treatment modalities and practices, ask more questions, figure out, if this is the practice that you do want to go along with and feel is a good fit for your goals. If you're supporting someone with an eating disorder, try to refrain from making assumptions and generalizations about them, their abilities, and the function of their behaviors. This can sometimes become a challenge when perhaps you have your own experience of an eating disorder. You might assume that you know exactly what someone else is going through because you've gone through something similar. And while there may be a lot of similarities and points of connection, which can be really great for rapport building, your experience is most likely different from theirs in many ways. And so it's really important to keep that in mind and have an open ear to hearing about that experience.
So next up is autonomy. So we know that individuals are ultimately responsible for their own choices and health behaviors. And at the same time, individuals have the right to make whatever health decisions they choose without running the risk of being turned away or terminated from healthcare. Because eating disorder symptoms are observing people in many ways, it's common for folks with eating disorders to be in denial about the seriousness of their own conditions at times. And so this denial has led to the use of involuntary hospital admissions and treatments for eating disorders. While this is no longer a common practice in Ontario, and while some people may attribute their recovery to such measures, there is some evidence to suggest that the long-term outcomes of people treated on an involuntary basis might be worse than when treated on a voluntary basis, which is very unsurprising to me. Additionally, and also unsurprisingly, people are more likely to trust treatment providers and be willing to seek care if they feel that their personal goals, wishes, and perspectives are respected. And so harm reduction really centers the individual in this sense. And so, those service providers offer suggestions and education about treatment options. The person who's seeking that should ultimately make their own choices about medications, treatment, and health behaviors to the best of their abilities, beliefs, and priorities. And so within a harm reduction framework, provider, service, user partnerships are centered on collaboration, reciprocal learning, so learning from each other, and again, like client-driven care. So if you're someone living with an eating disorder, considering how to intentionally set aside time to co-plan with supportive people, whether that's a treatment team, caregivers, friends, to get tailored resources and support. Having a plan often minimizes anxiety or surprise from how people will react if and when they see you engaging eating disorder behaviors, and it allows appropriate safety responses to be outlined. So for example, when it would be appropriate to take you to the emergency room, let's say.
And so lastly, we have incrementalism. And this means that any positive change is a step towards improved health. Ultimately, change is non-linear and it takes time. In terms of practices, how that might look like, it could be celebrating positive movement for both, people living with an eating disorder as well as those supporting them. And this includes, when we say positive movement, it can include things like recognizing the social connection it facilitates, the exhilaration of a competition, feeling grounded or relaxed by it, nurturing a new skill or perspective, maybe learning something new about yourself or in others when you're engaging in this movement. We're also normalizing plateaus and setbacks. So while the reemergence of old symptoms can sometimes feel like a backwards movement, this can be a really great opportunity to develop further understanding of really what's working and what's not working. Medical monitoring can also be really important in harm reduction approaches, and small changes in behavior can lead to improved medical outcomes. Reducing harm or the dependence on eating disorder behaviors may also mean learning new skills to regulate emotions, tolerate distress, and manage interpersonal conflicts. And a harm reduction approach would prioritize increasing opportunities to develop new coping skills. And this can include joining kind of skills building groups, so having skills training in DBT or CBT, and kind of engaging in recreational opportunities. So, finding a hobby or activity group. As well, adapting one's goal really, depending on the context, is a really important aspect of this. And so when we're thinking about the holidays specifically, maintaining the current state is sometimes the best we can do. And so having that as the goal can help prevent that kind of setup of higher expectations or, failure or quote unquote relapse, because we're setting our goal as, just maintaining the current state. Because expecting ourselves to change during this really heightened time can be really unrealistic.
Okay, so now we are going to go through some really specific, like symptom-specific harm reduction examples. So if you are feeling that this isn't the right time to listen to that, feel free to step away. But we're hoping that these are some concrete strategies that can be applied, like we said, to this time of year, but really to any time of year. Okay, and I will say that we didn't come up with these, so I don't want to take credit. There's an article that we will link to at the end. The source is this Medrano 2021 article, and this author outlines, it's a really great article, and they outline a lot of different specific examples. Okay, so here are some specifics. So when it comes to over-exercising, some ways to practice harm reduction include stretching and warming up, working out or exercising with another person, or being in a group or class setting as opposed to, by yourself, maybe at night where people don't know where you are. Incorporating slower movements. That should say movements, not moments, like walking or swimming. If exercising alone, keeping your phone on you or telling someone where you're going, and listening to slower paced music. Research shows that apparently that does influence, how hard someone might push themselves. Same with driving, I think. I think we drive faster if we listen to like higher or faster paced music. When it comes to restricting, some harm reduction examples include taking multivitamins and supplements as recommended by a healthcare provider who knows your specific individual body and health. So I wouldn't ever want to make like broad recommendations for everyone, since everyone's different. Exploring resistance-based exercise to the extent that the body can safely handle, to help keep bones strong, as opposed to, and this of course relates to exercise, but instead of like simply cardio exercise that can be really tough on the joints, bones, avoiding exercise that involves motions that bend or twist the spine, or contact sports, or those that involve a higher risk of falling. And then incorporating safe foods into some sort of baseline intake or nutrition goals in order to increase volume. So it's better to eat, more of the things that feel comfortable than to not eat anything at all. With binging, some examples include trying your best to eat slower. We know that binging is often done in a more dissociated state. So trying to incorporate mindfulness if that's accessible. Taking a short walk afterwards can sometimes help with digestion and discomfort. And similarly, adding a hot compress to one's stomach might help if they're experiencing pain while digesting. And then the last point here also refers to mindful eating. So this idea of noticing fullness cues, which isn't accessible to everyone, but if that's something that you are in touch with, exploring what that feels like. When it comes to purging, there are a few more examples here. So if engaging in self-induced vomiting using one's hand instead of a foreign object is a method of harm reduction, and educating yourself on the dangers of asphyxiation when using objects. Watching out for things like blood. This might indicate that there's something more severe going on that you should receive immediate medical support around. Waiting at least an hour after vomiting to brush teeth or consume like sugary or acidic foods, because that can help protect the enamel on the teeth. So instead of using toothpaste, considering mixing baking soda with water and rinsing in the meantime. There are also different enamel building toothpastes and other dental care strategies that can be incorporated. We actually held a webinar on dental care tips for folks with eating disorders in January of this year, so almost a year ago. But that webinar is available on the Sheena's Place and Genetic YouTube channels if you're interested in checking it out. And then lastly, drinking Pedialyte or Gatorade, something with high levels of electrolytes, to restore electrolytes when vomiting and when using laxatives or diuretics. And so knowing as well that electrolyte abnormalities are really a major risk factor for mortality from an eating disorder. Okay, I know that was a lot of detail. I'll pass it over to Emily to take us through some more specific holiday examples.
Thanks. And so when we're thinking about specific holiday ones, these are kind of some tips and strategies you can think of in those social gatherings as we're planning for different kind of holiday events you might end up attending or not attending. So eating foods that feel safe and letting yourself have permission to not challenge yourself to face all of your foods at once is really important. This is already a time where there's heightened emotions going on. And so it's not necessary or, any indication of who you are as a person if you choose not to challenge yourself with those fear foods. In fact, it might be a lot safer and easier for you to cope with how difficult the season may be if you refrain from that. Related to that, try bringing safe meals and snacks with you to events in case that, there are kind of triggering foods or kind of options where you feel like are inaccessible for you. If you have your safe kind of foods with you, at least you'll be nourishing yourself. And that is always better than not having anything at all. You can also try calling ahead to find out what kind of food will be served so that you can prepare mentally. Prepare mentally in the sense of having your coping strategies ready, knowing what to expect. As well, maybe figuring out who is attending the event if you can. This could really help you, and if you're going with a support person, plan for navigating those conversations or situations. So for example, if you were attending a dinner with your partner's parents who are unaware of your situation, having your partner ready to redirect and set boundaries ahead of time might be really helpful. It's also really important to kind of identify a support person who you can text or who you can call if you are feeling distressed or triggered, whether you need an out, someone who can bring you out of the space, or someone who can help you cool down and de-escalate in the moment. It can be helpful to make a plan for after an event or a situation that you anticipate will be difficult. So that might just be a holiday gathering. And if you're unable to spend time with family or loved ones, and you're worried about not feeling safe home alone, schedule activities that bring you into the community spaces that you're comfortable with. So that might mean visiting a very specific coffee shop, one that's full of routine, it's very familiar to you. Maybe the baristas there. It might be going to a pet cafe. It may be going to a gallery or a museum. Whatever you are comfortable with that brings you into a space where you can kind of be in contact with other people, but you can also have the opportunity to have your alone time. And then as well, consider joining an online support group, a peer support group, and reaching out to crisis resources if needed. And this might be in that moment when you are in a heightened state. It might also be ahead of a time before you're going into a holiday event and you're trying to pre-plan, you're trying to prepare yourself for it, feel free to reach out to, for example, NETIC's helpline. Sometimes crisis resources can be a great kind of pre-call or debrief resource, as well as one in the moment. And so these are just some examples that we thought of for the holidays where you could apply some harm reduction practices to. And now Caitlin will kind of go over some medical support red flags to look out for.
Yeah, before I move on, I'm actually curious if anyone has any other examples they want to add to this list. Anything that you have done in the past or you've suggested to someone else, or thoughts about what could be done this year. We'll just take a moment to see if anyone has any other ideas. Yes, so someone has written in the chat, nourishing themselves before the gathering. This is a common narrative, like a common diet culture thing, is this idea of like saving room or kind of like pre-compensating for eating. And ultimately that can reinforce either things like binging, feeling out of control around food, not feeling safe around food. Yeah, so bringing snacks, purse snacks, love it. Bringing comfort objects as well. Totally. Setting boundaries, keeping yourself busy, using Meetup and Eventbrite to stay connected. Those are great ideas. I like having comforting photos on my phone as well, like photos of my dog that I can just, look at if I'm feeling overwhelmed. So that could be one to add as well. Thanks, everyone. Okay, so moving on to some medical support red flags. So these are some things that, if experienced, it would be important that someone seeks immediate medical support. So going to, let's say, an emergency room or a walk-in clinic, depending on the severity. So this includes suicide risk, deliberate and like dangerous self-harm, a heart rate that's below 50 beats per minute, difficulty breathing, especially when lying flat, deterioration in consciousness, arrhythmia or chest pain, severe hypotension, pins and needles in the toes, so losing sensation, or bleeding in, let's say, vomit or stool. Something that we did want to note here is that if someone is interested in accessing a hospital-based eating disorder treatment program, they would need to receive a referral from a doctor. That could be your own physician or a physician at a walk-in clinic, but an emergency room admission will lead to short-term medical stabilization, so hydration or other things that might be required, but not a referral to an eating disorder treatment program. So that's just something we wanted folks to keep in mind. So in the last part of today, we'll move into sharing some resources, and then we'll have lots of time for Q&A. So I'll pass it over to Emily.
Thanks. So you'll see on this page over here, we've listed some kind of general treatment and support options for information, as well as, finding local or kind of accessible treatment options, whether that's provincially funded programs or a private therapist or nutritionist. You can access a service provider directory, as well as the helpline and live chat at NETIC. The information is over there. There is a link over there for in-depth kind of information around programs in Ontario that are hospital-based. We have community-based treatment programs like Body Brave, as well as obviously kind of more private therapists and clinics. And then we have community-based group supports, which Sheena's Place falls under. And you'll see that there are many other kind of options here. Most of them are free. Some of them are low cost, so they're offered at a reduced rate. And you'll see that there are some available for youth, adults, and caregivers. Over here, we have some kind of helpful starting off points for resources, things around, a guide for supporting a friend, or if you're a parent and caregiver, how to support a youth. There is also this second last link over here, Center for Clinical Interventions, some self-help worksheets and workbooks that can be really useful and accessible, as well as an additional harm reduction kind of resource there for you to look at. If you're looking for more resources on medical monitoring, we have a list over here. And then in our next slide, we have these resources specific to the holidays. So there's one that's on responding to diet culture that's been developed by Sheena's Place and Planned Parenthood Toronto. Both Sheena's Place and NEDIC has a coping with the holidays resource. The Sheena's Place one is quite long. It's more of a kind of worksheet style. The NEDIC one is more of a concise, short kind of list of tips to keep in mind. And then we also have a list of local kind of food banks and community fridges, because we do know that food insecurity and access is really important. There are some additional articles over here that talk about diet culture during the holidays, some things to consider information-wise, as well as some strategies on maybe how to respond to fat talk and all of that. Okay.
Okay, so we have lots of time for questions. We don't need to fill the whole time, but we have the time if we need it. So Emily and I will look through the chat. We'll try to go in order. And so you're welcome to add questions in as you think of them. And if we skip over yours by accident, just let us know. Okay, so the first question that I see here says, in your opinion, is there ever an appropriate time for someone to be hospitalized, i.e. severe malnutrition, because they are unsafe, acutely at risk, although this may not be voluntary? I have heard in ED education spaces that those who are very malnourished are often unable to make
Caitlin, sorry, Caitlin, the question's being read a little quick. I've missed the end. Could you please repeat the latter part of the question?
Yes, I have heard in ED education spaces that those who are very malnourished are often unable to make decisions due to severe degree of malnutrition. I think this is a very good question. I think it's a huge ethical question and like philosophical, ethical dilemma that applies beyond eating disorders. So the idea of like self-determination and the ability to make one's own decisions, and where do we draw the line when someone is no longer able to make medical decisions or other decisions for themselves. So this is probably not what you want to hear, but I don't think I have an answer to that because it's such a huge question. Emily, do you have anything to add or share?
I agree with you on that. And I think the work that we're doing when we support people, and if you're a support person in someone's life, we want to get them to a place where we don't have to consider this, where severe malnutrition isn't what they're struggling with, and that heightened risk. And I think a lot of times when we're considering something like involuntary admission, having these transparent conversations with people living with eating disorders, those that we are supporting, can be really important, because no one wants to go through a traumatic experience of getting forced into treatment. And so I think there's no easy answer to this. and having the awareness that this may be something that might happen, or people may be acting uninformed and may do things that will result in kind of involuntary admissions into the hospital, can be things to consider when we're planning around harm reduction. So maybe the goal isn't abstinence and going full throttle into clinical recovery, but maybe like, while we're keeping this in mind, how do we keep safe in the meantime so that we don't get to a place where severe malnutrition and that admission can happen? Sorry, I don't know if that's very helpful.
So the next question I see is someone asking about someone else who deals with binge eating and has been following structured eating, but they are going on a cruise during the holidays with unlimited access to food. This person has started feeling hunger cues more during the day, and can we provide some suggestions to help this person manage during the holidays? I guess, I can start by saying, like, broadly speaking, binge eating, I kind of see it as a response to two main types of situations. So one being restriction, food rules, and then another being like coping with difficult emotions, traumatic memories, etc. And so I think it would be important for this person, or for anyone, to maintain regular, consistent eating. So not going, long periods of time without a snack or a meal. That would decrease the likelihood of binging. And then to anticipate, what might trigger or bring about various difficult emotions during this time, and planning around other coping strategies that can be used if those emotions or situations do arise. It really depends on the individual as well. Emily, I'll pass it to you.
Yeah, I don't have too much to add to what you said. I think if this person is, starting to feel their hunger cues, that's a sign that maybe that's something they have access to. And so perhaps not during the holidays, when there could be like a lack of support or kind of ability to reach out to supports and heightened kind of situations around diet culture. But at a later date, it might be worth kind of exploring tapping more into intuitive eating, if that is something that they are interested in and they are able to feel, because that won't be accessible to everyone, but it sounds like for this individual, it might be something that they want to explore.
Okay, the next question, more of a administrative one. Someone is asking about their eligibility for Sheena's Place programs if they are located outside of the GTA. Our groups are available to anyone in Ontario because most of them are virtual. That's the limit, the whole province. And then in person would just be anyone who can get there in person. Okay, the next question is, at what point would a person's self-harm require medical attention? They are asking because for some, they believe self-harm can be a part of harm reduction in some way. I absolutely agree with that. Emily, do you want to start this one?
Sure. I think this will definitely vary for the individual and kind of the context that they're in. When we are talking about harm reduction practices and plans, we're always talking about it in the context of working with a professional to monitor and discuss what those safety plans look like. Part of that safety plan might be getting medical attention if, at that point, someone has engaged in self-injury, for example, and they're bleeding out. But it could also be if there's someone in their space, and part of that plan is for them to have the kind of medical equipment to bandage themselves and then go to a walk-in clinic afterwards if needed. That could be another way. I think it's hard to kind of make a broad statement around it, because you're right, for some people, self-harm in the different ways that it can occur can be a part of someone's overall harm reduction plan. And I say that as in, for many people engage in self-injury, that might be their way of trying to cope with eating disorder thoughts or feelings, and vice versa, or substance use. And so some people might end up engaging in those behaviors, but trying to find safer and kind of less heightened or dangerous ways to engage in that, but it is their way of coping with this other situation. Caitlin?
Yeah, I agree with what you shared. I think I'm not an expert in this area, but I imagine there are resources online that give more information about what sort of physical signs to look for, like we did with the eating disorder medical red flags. So at what point would, let's say, self-injury be getting to a point where it could be life-threatening, or leading to something more severe like infection. So I don't think I can share anything more specific, but I imagine there is that information out on the internet. Someone is asking if an ER doctor could complete a referral form for a person hospitalized for their eating disorder, or does it have to be from their primary physician or walk-in doctor? I believe it has to be from the primary physician or walk-in doctor. I do not believe that. Am I correct, Emily?
I think a doctor at the ER can make the referral.
Oh, they can. Okay.
Oftentimes, it's more so that there's no doctor available to make that referral. There might be like psychologists on site who are able to make that assessment that, yes, this is a concern and that they should kind of go into treatment, but they might not have that ability. But if a doctor is available, I have kind of supported clients who have experienced where the doctor was able to make that referral. I think it's probably more likely to happen if the hospital you're at has an eating disorder program and the doctor is aware of that as well. Not every doctor is going to be informed, so it's not likely. And if you have access to a primary physician or a walk-in doctor, that's usually a safer route to go. But if one is available, it could be an outcome.
Thank you for clarifying that. So the next question, for practitioners who don't work on teams with medical practitioners, should we stray away from harm reduction strategies such as replacing electrolytes, given concern for things like refeeding syndrome? How do practitioners navigate medical risk for clients who are unable or uninterested in being followed by physicians or other healthcare providers? That's a good question. I can't say that I have enough knowledge on something like refeeding syndrome. As a social worker in a community setting, providing group-based support, it's not something that would intersect with my specific role. But I think, in the spirit of harm reduction, like supporting someone in setting the goals that they want to be setting. So maybe that goal is developing more comfort in seeking medical support or finding a new practitioner. That could be a part of it. Obviously, some people don't want to seek medical support at all. And I think a lot of this has to be an individual decision around like someone's comfort level in providing care to someone. I know some social workers who require their clients to seek medical monitoring if they're going to be seeing them in like a private practice setting. Let's say they say that's what I need in order to provide support for you. Others might not. Emily, any thoughts?
I agree. I don't have anything to add, I think.
Okay, the next question. What is the best framework for responding to a loved one who may disclose that they are experiencing a reemergence of ED symptoms or urges during the holidays? Is there questions to ask that may help to clarify what they need during that time, or a way to respond that would be more likely to leave them feeling heard and supported? Emily, is there, I mean, some of the NEDIC guides of like how to support a family member or friend, I think some of those would be quite relevant to this situation.
Yeah, I think so. I think a lot of the general ways we want to frame questions is keeping in mind our own biases and beliefs, and how that might kind of translate across, and using really open-minded language and I statements to express your concerns if they're, talking about this, as well as asking questions to understand a bit more about what they're looking for, whether they want to access additional support, or maybe they've accessed help in the past before and this is something that they'd like to explore again, but maybe for some people they don't. So I think rather than making assumptions, being really honest and kind of gentle with your language when you're asking them about how you can support them could be a general kind of approach. On the NEDIC website, there is a page called Help for Someone Else. It's under the Get Help tab. There are kind of examples of ways that you can ask questions and provide support at meal times, when socializing, or in kind of difficult situations and stuff. So that might be a link to check out.
I'm seeing in the chat, to follow up on the referral question, someone is saying that some programs allow allied health professionals to refer. So this person is a registered dietitian and they have referred people to eating disorder programs. So that's good to know, but it does sound inconsistent across the landscape, which is frustrating.
Yeah. I think
oh, sorry, go ahead.
Oh, sorry. I think too, depending on the province, sometimes like nurse practitioners can have the same role as like a doctor, but in Ontario, the main kind of referring professional and provider is a doctor. But yeah, thank you for bringing up that point in the chat.
So the next question, do you have any advice for people who restrict when there isn't safe foods available, especially with constant comments and judgments about how much they eat? That's a tough one. I guess what comes to mind for me right away is thinking about, like, are there any other aspects of the eating experience that can be made to feel at least a little bit more comfortable or a little bit less triggering or stressful? So for some people, like, that could be eating alone as opposed to eating in a group or eating one other person, eating in a specific spot at the table, watching TV while eating, or reading a book, listening to music. So whatever, if there's anything that can make the situation a little bit better, that's something to think about. And also challenging some of the all or nothing thinking that might be coming up. Is there a safer food, right? Because I think often the eating disorder voice can create categories of like good, bad, safe, unsafe. Is there any room in the middle to consider something that is like the next best thing?
Yeah, knowing that, I think trying is the key part. And so even if you're plating it, having a small portion to try that safer food, or maybe it's starting off with a drink, or for some people, it might even be like a textural thing, sensory, their relationship with restriction, right? And so is there something else available that might be able to substitute something that's a little bit safer in the sensory and texture aspect?
Yeah, good idea. And the last question I see in the chat says, any advice for staying with family during holidays and being back in some of the childhood dynamics that influenced the eating disorder? That is a great question. And I imagine that it's a common situation or concern for folks. Emily, do you want to answer this one first?
Yeah. I don't have any solid thoughts, but as I'm thinking of it, I think it might, I mean, I imagine it would really depend on whether family is aware that you know, have an eating disorder, you've had treatment for it, or whether they've supported you in the past with that before, because that might give you more opportunity to have more direct and transparent conversations around boundaries if you know that you're stuck in this situation, and especially if you actually want their support, or you're really hoping that at some point of their life that they will change some of their attitudes and behaviors towards food and body. I think it's a lot more challenging maybe if this is something that you haven't really talked about with them before and they aren't aware of. um, in that case, I think maybe those strategies around how to redirect conversations, create safe spaces for yourself inside the home, whether that's like your bedroom, going to a place where you can lock the door, having friends available who can, call you and you can step out of situations. Those might be other ways to kind of safely get yourself out of triggering situations if those are coming up. Those are some of the first things that pop up to my mind. Caitlin, anything to add, jump off of?
I agree with everything you said. The only other thing that comes to mind is, I mean, just like paying attention to when that's happening, right? Like when those dynamics are being triggered, and noticing that, oh, this might be like a past dynamic that is like being triggered right now, and it's not that there is necessarily something happening in the present moment. So like it depends on what it is, but if you are in the moment safe, like reminding yourself that I am safe now, this is a past thing that's coming up. But of course the emotions can be really strong, and that reminder might not be enough. But yeah, know that whoever is experiencing that definitely isn't alone in going through that. I think that can come up a lot. Okay, so we have 5 minutes left if there are any other questions. In the meantime, we did share a link to an anonymous feedback form in the chat. You'll also receive this by email at 6:30, along with another link to the slides. We would love your feedback. This is, we've done a version of this webinar in the past. One of our former Sheena's Place students did a harm reduction webinar in March. And so I should have credited her right at the beginning, but that fled my mind. Credit for much of the content of this presentation goes to Miranda, who did develop this as part of her placement. She gave us her full permission to use the content for today. So we love feedback. So let us know what you liked, what you didn't like, and we can improve our webinars going forward. Someone's asking if they can share the slides with colleagues. You're absolutely welcome to share the slides. We'd recommend sharing the recording link along with it, because there can be some context that's lost when you're just looking at the slides. But everyone will receive an email once the recording is available. And again, that will be on YouTube. Thanks so much, everyone, for joining and for sticking with us until the end. Wishing you all a restful evening. and hopefully a holiday season that fulfills the needs that you have, whatever those might be.
Yes, thanks everyone.